everyone. This is Ernesto Maddaloni. I am Associate Professor of Endocrinology and Diabetes at Sapienza University of Roma. And I would like to thank Medea for the kind invitation to talk about an important topic today.
What are the risk factors for developing prediabetes/intermediate hyperglycemia?
Thank you for the question. So the pathophysiology of prediabetes and diabetes is quite complex. However, within this complexity, we can identify most important factors which mainly relies in the development of insulin resistance within the vicious cycle of obesity, hyperinsulinemia, and insulin resistance. This is also called as a maze with no exit, where the development of insulin resistance is causing hyperinsulinemia, and which is then causing obesity. And obesity itself may further worsen insulin resistance through the development of low-grade inflammation. There are mainly three working hypotheses to define the pathophysiology of prediabetes, diabetes within the diabesity pandemic. The first hypothesis involved inflammation, the low-grade inflammation. The second hypothesis involved the lipid overflow, which is strictly connected with the increased reservoir of ectopic deposition of lipids and adipose tissue, which also contribute to the third hypothesis, which is called the adipocrine hypothesis, due to the endocrine activities of the adipose tissue. So overall, there are some factors that we can clinically identify which affect insulin action and secretion, which are the two main pathogenic moments related to the development of diabetes. So these factors are the increasing in body weight, the decrease in the levels of physical activity, which interact, of course, with the genetic predisposition and epigenetics factors. On these baseline factors affecting insulin secretion and insulin sensitivity, then there are other less important but still overcoming factors related, for instance, to the presence of smoking or to the development of other disorders such as liver disease, renal impairment, which then may contribute independently to the development of prediabetes. It is important to note that in prediabetes, the first physiological phenomenon is an increase in insulin level, an increase in insulin resistance. But then, when prediabetes develops towards type 2 diabetes, while insulin resistance continues to stay high or even increase over time, there is a loss of beta cells. So, if we want to intervene to decrease the development of prediabetes and diabetes, we should intervene very early in the pathophysiology of insulin resistance before that the function of beta cells starts to decrease. And from the epidemiological point of view, this is very, very important because increasing body weight and obesity is a real pandemic. Now, more than 50% of people living in the US are affected by obesity. It is estimated that globally, more than 1 billion people will live with obesity by 2030, and this emergency starts very early in life. We have a very high number of people, adolescent people, or even pediatric people, affected by obesity.
What lifestyle intervention programs and patient support are needed to sustain treatment benefits long term?
Thank you for the question. The answer is very easy from one point of view, but then the implementation, the answer that I'm going to give you, will be quite more complex. So now, to answer to your question, I would just take the note of my last concept of the previous question. So we have introduced the concept of pediatric obesity, and to understand what are the intervention programs that we should implement in the whole population to prevent the development of insulin resistance, and also to sustain the long-term benefits, we should start very early in life, and we should start to ask our questions. So why people become insulin resistant, why people become obese, and in particular why our children are becoming obesity. So there are data that clearly show that in Western countries, also in Italy, where actually I work, there are very bad dietary habits, both in children, but also in adults. And all the story starts when we are children, because the habits that we develop during childhood are then also kept during adulthood. For instance, our children usually do not have a healthy breakfast. Actually, about 10% of our children actually does not have breakfast, or breakfast is very important. They usually, more than half of our children have a very heavy and carbohydrate and lipid rich intermediate break during morning or during the afternoon, with a lot of sweetie snacks. There is a very low consumption of protein. Furthermore, also the physical activity is not performed enough, both during childhood and also during adulthood. About 1 out of 3 children does not have any kind of movement or free play during the week. If we want to improve our health in relation to insulin resistance, so we should work to have lifestyle interventions that are aimed to decrease the amount of adipose tissue, in particular the amount of the white adipose tissue, because if we decrease adipose tissue, there is a huge increase in insulin sensitivity. And together with the increase in insulin sensitivity, there is a decrease in the low-grade inflammation related to obesity, which, as I said just a few minutes before, by answering the first question of this interview, the development of the low-grade inflammation is strictly related to the development of insulin resistance within the vicious cycle of insulin resistance, obesity, and hyperinsulinemia. So, trying to give you very practical advices about the lifestyle intervention programs that we should implement in our daily life, I think that we should implement a multidisciplinary intervention, which should include diet, physical activity, and behavior therapy. The therapy with diet, physical activity, and behavioral therapy should be aimed to achieve at least a 5% weight loss in people that are overweight or obesity, but it is at least 5% and should last. The recommendation actually are that the intervention should last at least for 6 months. Now we know that as soon as we stop this intervention, then there is a weight regain, there is an increase again in adipose tissue, an increase in insulin resistance. So I would say that we should aim for interventions that are sustainable during the whole life of our patients. I am a fan of Mediterranean diet, which in my opinion is the type of diet that has the higher amount of evidence related to the improvement of insulin resistance. Mediterranean diet is a well-balanced diet that allows the consumption of all the macronutrients that are important for our health, including a 50% carbohydrate, but be aware that these are not simple carbohydrates. These are not. This is not sugar, but we are talking about complex carbohydrate. There is a very good amount of fibers, more than 30 grams per day of fibers, then proteins in every meal. There should be a representation of protein for a total amount of protein that is about 0.8 to 1 gram of protein for every kilogram of body weight, and also lipids, but not monounsaturated or polyunsaturated fatty acids for a total amount of 30% of lipids. Finally, but so last, but as we say, not least, actually it should be probably referred. One of the most important intervention is physical exercise. Current recommendations for the prevention of insulin resistance, prediabetes, and diabetes are to perform more than 150 minutes of physical activity of at least moderate intensity for week, and there should be every kind of physical activity is good. So we should find the physical activity that our patients is able to perform, depending also on the comorbidity, and also that our patients like to perform. So it should be really a personalized program of physical exercise. Physical exercise that should be both aerobic and strength exercise, and for elderly people developing insulin resistance, we could also suggest flexibility exercise such as stretching or yoga, or some kind of aerobic exercise that is more easy to perform during elderly, such as walking or even dancing. The most important thing is that physical exercise should be performed at least one each other day.
Prediabetes/intermediate hyperglycemia is a serious dysfunction rather than a pre-disease. Is enough being done to educate and identify patients on the risk factors?
And to highlight the first part of this question, so that prediabetes and intermediate hyperglycemia are already you said that it's not a pre-disease, it's a dysfunction, and I am totally agree. It is already a disease. It is now clear, there is plenty of evidence showing that the complications of diabetes, and in particular the macrovascular complications of diabetes, are already present in an important percentage of people affected by prediabetes. And this is due to the effect of insulin resistance on the endothelium. Insulin resistance is associated with an increase of the vascular tone. This is due to the complex biology of the insulin signaling within endothelial cells. I had the opportunity to study this signal while I was at the Joslin Diabetes Center, and we clearly showed that with at least two different molecular pathways, an impairment in the insulin signaling in endothelial cells is associated with a decrease in the production of nitric oxide. If there is no production of nitric oxide, or the reduced production of nitric oxide in endothelial cells, this then translates in decreased vasodilation, and so an increase of vascular tone, and an increase in the blood pressure, stress of the vascular wall, and increase of atherosclerosis, and then of course an increase of cardiovascular events. So that said, you are asking me whether it is enough being done to educate and identify patients with risk factors, and unfortunately the answer is no. We are not doing enough. This is clearly showed by the new data that have been released by the International Diabetes Federation, who are showing that there are in the world more than 600 million people, or about 12% of adults living in the world worldwide, that are estimated to be affected by impaired glucose tolerance, which is one of the definitions of prediabetes. Furthermore, there is also people affected by impaired fasting glucose, that is about 500 million, or 9% of the global adult population affected by impaired fasting glucose. Now, of course, these numbers are different considering the different regions of the IDF, but it is clear from these numbers that we are not doing enough to identify patients, people that are at risk of developing type 2 diabetes, of developing complications, vascular complications of diabetes. So we need to act early. We need to improve our screening programs to identify people at risk of pre-diabetes. Indeed, the detection of this intermediate hyperglycemia may provide a target population which may benefit the most from our preventive strategy and from our interventions to defeat the pandemic of cardiometabolic disease worldwide.
How may guideline recommendations for screening high-risk individuals, for example, those with gestational diabetes mellitus or polycystic ovarian syndrome, be implemented globally?
There is plenty of guidelines from several different international and national scientific societies working in diabetes that strongly suggest the implementation of screening programs to early identify the target population we were talking before. Unfortunately, the implementation of such guidelines needs a full support from healthcare professionals like me, but also from the governments worldwide, because we are talking about a very high number of people that should be screened. So these screening policies should take, of course, into account, for instance, the different prevalence of prediabetes and type 2 diabetes within the different IDF regions, but also among people with different age. For instance, we know that there is a higher prevalence of prediabetes in people that are aged more than 50 years, or while a little bit lower for people that are aged for higher than 70 years, for instance. And so we should, first of all, identify the population that might benefit most from the screening programs. Now, the screening programs should start also from the identification of people at high risk, probably through questionnaires. It would be very nice to give the opportunity to all people worldwide to perform lab testing like HbA1c or glucose testing, or a glucose tolerance test, for instance, which may, of course, identify patients with prediabetes, but we cannot do this at large scale. So to identify the population at high risk, we could use screening tools such as the Q-diabetes risk score or the Finnish diabetes risk score, which are very easy scores with like 8 to 10 questions. Patients and people may perform alone at home. After completing this questionnaire, the patient will have a final score suggesting or not to refer to the doctor or to the diabetologist for further screening, for instance. There is a clear position from the ATA stating that the screening for pre-diabetes should be done with an informal assessment of risk factors in asymptomatic adults, and this may be done, for instance, for already by general practitioners. Again, I would like to highlight the importance also to start to identify risk factors for prediabetes and the presence of prediabetes already in children. In the last decade, the incidence of type 2 diabetes in adolescents has increased dramatically, especially in minority population. And so testing to detect pre-diabetes should be considered also in children and adolescents that already have risk factors such as overweight, maternal history of diabetes or of gestational diabetes, or children that develop polycystic ovary syndrome, for instance, or in the presence of signs of insulin resistance, such as dyslipidemia, or in people that were born with or affected by small for gestational age. Another opportunity that we are starting to have in our hands to implement a new modality of screening for prediabetes might be in the future also the use of the novel technologies such as the continuous glucose monitoring, which seems with new data and new evidence seem to support for a future use of this technology for a more wider screening of prediabetes and type 2 diabetes.
What take-home messages do we have at the end of this interview?
Prediabetes, insulin resistance are already important chronic disorders that should be screened, diagnosed, and treated as soon as possible. It is very important to identify patients at risk of insulin resistance, of prediabetes, and of course of type 2 diabetes during the different stages of their life, and do not forget to focus also on children with overweight, obesity, and try to tackle the pandemic of prediabetes and obesity already during childhood.